nice message. Thank you so much, Jillian. Talk less, do more. I think that really epitomizes this panel and everybody in this room. We're all here for a reason. And I have the privilege now of introducing Dr. Wendy Oliver-Pyatt, who absolutely talks less and does more. We were the co-chairs of the Academy for Eating Disorders Advocacy Committee for quite a while, and we've worked very, very closely together for the past few years. And I remember sitting on calls and having to go through processes to get documents written and things done and things approved. Wendy and I would start emailing while we're on these calls. Oh, we can't stand this, let's just do it. Why does everything have to take so darn long? Let's do it and get it done. So, Wendy is a medical doctor. She's a fellow at the Academy, as is Dr. Jillian Kroll, who was recently voted into that position. She is the founder and executive director of the Oliver-Pyatt Treatment Centers. And do you still have one in, that's in Miami? Okay, recently moved to Miami, Florida. And her talk today is how obesity prevention can trigger eating disorders, why we need to address them, both of them in tandem. So, Wendy.
September 29th, 2010. To whom it may concern, Kathy L. is under my care for the treatment of a serious condition. This letter is a request for a medical waiver for Kathy from her health class. For medical reasons, Kathy should not participate in health class during the 2010-2011 school year. Thank you, Wendy Oliver-Pyatt, MD. September 5th, 2010. Hi, Wendy. It is with a sad heart that I write to you. I am not sure if you heard, Gina D. died this past Thursday night. I spoke with her dad Friday night. He said she had been struggling with her eating disorder pretty badly lately. She had been in and out of the emergency room and confined to a wheelchair. Thursday night, Gina stopped breathing in the middle of the night and passed away from her eating disorder. The girls from the center have been in contact, and we are all talking daily, hoping to make the service. Her funeral service is September 9th at 10 a.m. in Sacramento at St. Stephen's Church. Hugs, Caitlin. Let's define the pressure we are faced with. Our culture places significant impact on our appearance and pressures us to be unnaturally thin with low body fat, fit. Society tells us that dieting, defined as restricting calorie intake, ignoring internal cues, it's the way to be thin. We are bombarded with food, and we don't know what to do about it. The grocery store says it all. On the right, there's Coca-Cola, Sprite, and M&Ms. And on the left, the airbrushed models with fake smiles and fake bodies stare at us, leaving us feeling shame and inadequacy. The thought is something like, tomorrow I will eat less. Tomorrow I will exercise. Tomorrow comes with good intentions, but we all know the road to hell can be paved with good intentions. The war on obesity is one of those situations where the concept that the road to hell is paved with good intentions comes to mind. Let's talk about some examples of this. Kathy L. is the 17-year-old female currently under my care, referenced in the first letter. She came to me initially at a weight of 85 pounds in 2008, at a height of 5'4". She had stopped menstruating and had developed osteopenia, a thinning of the bones, and was at risk for infertility. Yesterday, I wrote this letter for her, requesting a waiver from personal fitness class, where she would be weighed, told her BMI, and instructed to track her calorie intake in the sake of health. I had to do this because the patient's eating disorder can be traced back to her first health class, a required subject, in 2008. If Kathy's mother were here, she would tell you about it. Kathy came home from health class with the idea that foods containing preservatives were not healthy. This well-intended family from Florida decided to cut out preservatives, which is a form of restriction. Eventually, the restriction became an obsession for Kathy, and little by little, additional food and food groups were excluded. In the patient's minds, these foods were dangerous, to the point that eating these foods is not something she can do. But she thinks she's doing the right thing. Panic, anxiety, and dread about eating have overtaken Kathy. In the beginning, she had anorexia nervosa, but 2 years later, the disorder has morphed into bulimia nervosa. Following the commands of the inner voice of the eating disorder, she restricts her calories during the day. And despite her fear and anxiety, the urges around food overtake her. At night, she binges and purges. Her mother sleeps downstairs near the kitchen, hoping she can stop her. Not everybody who's told to cut out preservatives in their health class will develop an eating disorder, but a few will go down. Remember that term gateway drug? The term is used to describe drug and alcohol use, which in and of itself doesn't seem to be dangerous, but can lead to addictions in some, probably genetically vulnerable people. How many of us tried drugs or drank alcohol in high school? Not everyone became addicted or alcoholic, but a few did go down. Day after day, a few are going down. A few of us are dying, and it's happening in the pursuit of health, the pursuit of fitness, and with good intentions. The second letter referenced above is from one of my former patients talking about the death of another former patient of mine, this one from California. It is real. There is nothing changed in the letter other than the name of the city and the church where the funeral was held. If Gina's father were here, he would tell you about how his daughter was heavier as a child, how she was teased about her weight. He would tell you about the co-occurring psychiatric problems she had as an adolescent and how this led to weight gain as she was entering puberty. Her anorexia nervosa was intense. Never again would she be called fat. But now, today, she is dead. Another patient was told by her doctor, "You're fat every day, so you should exercise every day." What do you think the outcome was? Did it result in positive thoughts, better self-care, or weight loss? This comment and these types of comments lead to shame, a painful emotion that gets burrowed into the psyche. Ironically, food becomes the way to bury the emotion. This patient's BMI was announced in her 3rd grade class. She cried to me when she told me the story. Over the next several years, she dieted temporarily and lost weight temporarily. But her weight rebounded when the metabolic and psychological impact of dieting took over. She had been losing and gaining the same weight for years. This is a term called weight cycling. Weight cycling is heavily linked to unhealthful, unnatural weight gain over time and obesity. Is the answer to this problem to tell the patient to cut calories? This patient's been told the same thing over and over by well-intended friends, family, and medical professionals. Exercise more, eat less. Which is also what Mrs. Obama's obesity prevention campaign is saying. If only it were this simple. Concern over rising weights has spurred community and school-based interventions and now federal interventions aimed at decreasing childhood overweight. These include mandatory screening of BMI and promotional campaigns emphasizing the danger of excess weight. Many professionals, health professionals, have concern about the safety and efficacy of these interventions, fearing that they will have little positive effect and may inadvertently contribute to over-concern with weight, shape, and unhealthy weight control practices. A substantial body of research from the literature demonstrates that an emphasis on appearance and weight promotes eating disorder behaviors. For example, when important agents in people's social environment, for example, parents and peers, endorse preference for thinness and place an importance on weight control, this contributes to body dissatisfaction, dieting, low self-esteem, and weight bias. Additionally, weight control practices among young people reliably predict weight gain, regardless of baseline weight, than that of those that do not engage in such practices, as referenced by Jillian. And thanks to Dr. Newmark for this fabulous research. It is important to evaluate the unintended consequences of obesity prevention programs, which will lead to unhealthy behaviors and weight changes. Unfortunately, very few studies have examined these effects of these obesity prevention efforts now on the rise. Research actually suggests that a focus on health, not weight, is key to avoiding harm. For example, Austin and others found that lowered rates of disordered eating in school-based intervention programs programs that promote health and healthy eating and activity patterns rather than weight or BMI. These findings emphasize the feasibility of simultaneously promoting body self-esteem and healthy lifestyle behaviors as others, such as Dr. Newmark, have suggested. Body weight cannot be evaluated in a vacuum, as is done when BMI is tested in schools. The BMI is not a reliable indicator for eating behavior, physical activity, and health. The middle of the weight spectrum can hide many unhealthy weight practices, such as bulimia nervosa, the condition that Gina died from. Although the public would never know it, controversy exists regarding morbidity, mortality, and weight. And some studies indicate that the higher weight deemed overweight is associated with lower mortality rates. I want to repeat that. The higher weight deemed overweight is associated with lower mortality rates. Based upon our genetics, many of us will be healthy while at a weight that charts deem overweight. Children and individuals in the situations will be set on a path of dieting and weight cycling. Again, weight cycling is repeatedly gaining weight over time, and in fact has been proven to be potentially more dangerous than a baseline high weight. According to the Academy for Eating Disorders and other professionals in the field, there are some important points worth noting. First of all, interventions must focus on health, not weight, and not BMI. Interventions should focus not only on providing opportunities for physical activity and health, but should also promote self-esteem, body satisfaction, and good feelings for bodies of all sizes. Interventions have to focus only on modifiable behaviors, such as watching TV and teasing, and weight is not a behavior, and so therefore it is not a target, not an appropriate target for behavior modification. Not all children are going to fit into the normal weight category. Using the term obesity prevention actually just throws more shame into those children and will leave them feeling powerless. Interventions must not use anti-fat messages and must not target heavier children. Determining normal growth in children is based on the consistency of their growth chart over time, which can only be determined by a healthcare practitioner who is trained in this area. Untrained staff in schools should never waste students and should not make references or form opinions about their health status based on weight. It is well known that at certain stages of the development, children will gain weight and fat on their bodies in preparation for puberty and growth. This is not abnormal. This is normal development. It is unacceptable for an untrained staff in schools to make a determination about a person's health based on their BMI. Weight must be handled as carefully as any other individually identifiable health information. Weight is private health information. It is simple as that. Weight, like any private health record, should not be maintained as a part of a child's medical record. Should only be maintained as a part of a child's medical record, never his or her school record, and that is the law. Representatives from the community who's going to be served need to be part of the planning process, and things need to be pilot tested and researched before they're implemented. Medical interventions have risks and benefits, just like when we do take new medications, they have to be tested ahead of time. Same with medical interventions and medical procedures. And those who are in a position to monitor and intervene have to be aware of weight cycling, eating disorders, obesity, and the frequently co-occurring psychiatric conditions that are coupled with weight gain. Otherwise, children in this experience will be short-changed with devastating outcomes. I recently received information about a new phone app available through Mrs. Obama's obesity prevention campaign. The apps are designed to promote health. One app is called Ration Roulette, another is called Eating Madness, and another is Food Busters, right up there with Ghostbusters, I guess. The apps are, I guess, supposed to educate children about food and promote health and fitness. In one of these examples, you win if you eat the lowest calorie food during the day. These apps reinforce the thinking that leads to restriction, dysregulated eating, eating disorders, weight cycling, and obesity. Eating disorders are serious mental illnesses with the highest morbidity and mortality of all psychiatric conditions. Up to 20% mortality is associated with anorexia nervosa. For every $159 spent on schizophrenia research, $1.20 is spent on eating disorder research. Damage is being done every day to our children in our schools who are weighed and told to lose weight by untrained, unknowing, and though well-intended school personnel. We wanted to do good in the world, but let's not put the cart before the horse. Albert Einstein is quoted as saying, "We cannot solve problems by using the same kind of thinking we used when we created them. We need more research, knowledge, training, and treatment approaches before we tell people what to do." We are all here to help forge a new path which will help those who struggle with weight, will not cause harm, and will be health-inducing for all. Please support the FAED Act, which will help us to wisely approach the health interests we all have in mind for our children. Thank you.